Hello and welcome to our next event tonight. And actually, we are back with Dr. Laura. So hi, Dr. Laura. Hope you can hear me. And how are you today?
Hello, good afternoon, everybody. I'm very well, thank you.
Happy to hear this, and welcome to our online patient meeting. And this is our first event tonight. There will be another one later on as well. But first of all, just let me tell you and thank to our ambassadors and partners for joining our initiative. And I just want to just remind everyone that without them, all those events, we wouldn't be able to simply have so many. So huge thanks for their support, and also to all our top experts like Dr. Laura today for joining us, our events, for sharing their experience, for sharing their knowledge. Thanks to that, we are able to still continue and support you any way we can. And we are always happy to do it. And tonight, again, we have another interesting topic for sure to discuss. And well, just to let you know, Dr. Laura García de Miguel, she is the medical director at Clinica Tambre, which is located in Madrid in Spain. And she will start with her presentation on importance of communication between the lab and the medical team in IVF treatment. Definitely important. So she will simply tell you a bit on that, and after that it will be time for your questions. So remember, all you need to do is just simply type in the questions in the chat section so that Dr. Laura can answer them for you. Don't hesitate, she will be able to help you, I'm sure. So any questions you have, just go ahead and type those in. And yeah, that's it from me at this point. Dr. Lara, are you ready to begin with your presentation?
Okay, thanks, Caroline. So today, this webinar is the name, The Importance of Communication Between the Laboratory and the Medical Team in IVF Treatments. We're going to talk about the importance of this communication between teams in a fertility clinic. It should be noted that not all centers are the same, as they do not have the same professionals. There are some parts that are outsourced and the protocols are different. This presentation is based to explain what we are doing in our clinic. I'm the medical director at Tambre Fertility Clinic, and I hope that whether you are one of our patients or from another center, I can help you to understand certain details of your fertility treatment. So, what will we cover? The topics we will deal are the next. So we have first, I will explain that what is involving in having the laboratories in the assisted reproduction clinics themselves, and I will talk about the stages in which the embryologists will be involved in your treatment. So you will also see how we communicate when dealing with a medical case, and finally, I will give you some ideas to keep. So we have in-house laboratories, and that's something very, very important to remember, that not all the centers have in their clinics, and sometimes they are asking to other laboratories with the treatment to help. So we, for example, have two laboratories, the andrology laboratory and the IVF, the in vitro fertilization laboratory. The embryologists on each team are specialized in the tasks they perform, and the laboratory director coordinates everything that is done. So in the andrology laboratory, we do perform spermiograms to check the general parameters and the quality of the sperm of each patient. We have the COMET fertility fragmentation test to check if there is any problem in the DNA, if there is fragmentation or not only in the single but also in the double brain. We have the possibility to do the genetic matching, the study of the recessive mutations for every patient or every donor. the chromosperm to check the genetical chromosomes disorders in the sperm freezing, and the sperm bank. In the IVF laboratory, we have of course, the oocyte retrieval procedure, the oocyte preservation for vitrification women and for donors. We have our in-house egg bank. We have the possibility, of course, to do ICSI procedure, and also we can carry out PGD, and also the possibility, of course, to do embryo transfers when necessary and vitrification of embryos. So having in-house laboratories as well as gamete banks allows for faster and more efficient coverage of assisted reproduction treatments, because communication with doctors, nurses, and patient care is more fluid. The procedures are very well defined, but at the same time, it is easier to personalize each treatment, approaching them from different perspectives according to professionals from various branches of science. So, in which moments of the treatment will you consult with the lab team? They are in charge of the RI witness system that I will explain later. They will also be involved in the embryo culture and will be updating of its development every day. They will do the embryo transfer with the gynecologist. They will perform the spermograms. And of course, embryologists have a significant role in gamete donation treatments. So this technique, this system, RI Witness, is a security system included in the treatment without additional cost, which identifies each patient's samples. The aim of its use is to avoid possible mistakes when manipulating or identifying the samples by using labels and individual identification cards. Before starting the process, patients receive a card with their personal data that is always used to verify their identity before obtaining any sample. Each tube, plate, or container is marked with electronic tags that are associated with the patient's card. These labels and cards are read by the witness at each step of the process, confirming the identity of the patient at all times. This system has receivers that verify the data independently in each phase of the treatment and are able to detect any alteration in the protocol used to identify the samples and to interrupt the process if necessary. So regarding seminograms, male patients will meet the andrologist team when they come to the clinic for a spermogram. Prior to this, our team conducts a short interview to be aware of factors that may affect the seminogram, such as medication intake, recent exercise, fever, etc. Afterwards, the sample is frozen and we Tambre doctors discuss the diagnostic with the patient if required. At this point, it may also be necessary to talk to the urology unit if there is important abnormalities. So regarding embryo culture and updating of its development, my patient and I talk about their options in choosing classic or time-lapse incubators at the consultation. As soon as fertilization takes place, the laboratory staff updates me on the evolution of the embryo, and they call the patients on day 1, 2, 3 of development to inform them as well. If the embryo is going to be frozen or a PGD is going to be performed, you will also be called on day 5. Otherwise, you will be with them and, of course, with me in the operating room during the transfer. So if you meet, if you're doing the embryo transfer, the professional will introduce and confirm the name and other details of the patient beforehand, because of course it's absolutely and extremely important, the security control at this step. Likewise, the woman will be informed again about the quality of the embryo to be transferred, and all the doubts she may have will be answered in terms of other embryos that could be frozen or any other questions regarding embryo quality. So regarding gametes and donation treatment, donor selection is a very rigorous process in which most of the clinic team is involved. The doctors and nurses are dedicated to carrying out tests and seeing them at different appointments. Our psychologist does a complete interview, and the laboratory team ensures the quality of the gametes. In addition, they are in charge of performing the genetic matching techniques between recipient and the donor, or both donor. So this slide is to inform about communication process between doctors and laboratory, and from a patient's or couple's first visit, we doctors analyze the case with the laboratory and ask for their opinion if necessary. As I said at the beginning of the presentation, the fact that the work under the same roof allows us to see each other, to discuss this type of matters, and if we cannot, we communicate by other means such as email or telephone. In addition, every morning we have clinical sessions where we discuss the next day's oocyte retrieval and transfers, current cases, and we make sure that all informed consents and other documentation is submitted. So as conclusions, embryologists, like the rest of the team, have a fundamental role in fertility clinics. Contrary to what some people may think, they have contact with the patients. They know who each person is, they know their name, they know their medical history. Communication between them and fertility specialists is crucial to thoroughly analyze which techniques and technologies will make patients fulfill their dream of having a baby. So thank you for your attention and take care.
Thank you, Dr. Laura, for that presentation. Definitely interesting to know how you cooperate, how the teams cooperate. And now, of course, it will be time for your questions. We don't have a first question yet, but I encourage anyone that is wondering, have any questions in mind, go ahead and type it in so that Dr. Laura can help you. I am sure you have plenty of questions. And so let's just let us know what is the most important thing for you. Someone is typing, so of course let's give it a minute in the meantime. If I just may ask about the RI witness card, I understand you have been using it not so long, but if you could tell me when did you start to use it? Simple as that.
We were the first visiting the first clinic having this technology in Spain. And it's, I would say, nearly 3 years that we are having this system. And I definitely recommend to all patients to confirm that their cycle will have this kind of technology, because it will ensure that everything is going to be all right in terms of security and no problems in terms of what selection of sample is possible, not okay.
Exactly, definitely. That sounds interesting to know that, it's nothing will, let's say, everything is protected. So any patients that is starting the treatment can be assured that, this is of course delicate matter for sure as well. So thank you again for that, and also answering the question. And we have a first question right here. So let's have a look at that. So do your embryologists call the patients every day?
Yes, of course. So my colleagues, the biologists of the IVF laboratory, call every patient in their language to explain about the development and about the evolution and quality of everyday quality of eggs, of embryos, whatever.
So they are in touch with the patient just like you are, actually, in fact. Yeah.
Yeah, and it's not that director, because my patients have lots of meetings with me via Skype or telephone. They have had the first consultation with me, so we have a very close relationship. But of course, with the biologists, they are during the laboratory part, very close to them, talking via phone. And if they are not available because the patient is working or whatever, they will write an email with the information of that day. And of course, if they have any problem in terms of understanding that, they are always available to talk again with them.
Okay, excellent. Thank you so much. And there is another one. Just give me a second. I just need to check. Okay, if you could, Michelle, perhaps add something, but here's the first part. Thank you so much for the presentation, very informative. Who make decision in whether the sperm, and there's another, I don't think, okay, sperm sample is good enough for fertilization?
So thanks a lot for your question, very important question. So before going ahead with the treatment, it's always recommended to come first, a first journey to the clinic to meet the atmosphere, talk with your gynecologist directly, and have the possibility to study the sperm and freeze a sample if everything is all right. So at this point, it's always biologists that will share that information with your doctor, and we will confirm if the sperm is absolutely fine to proceed with that. If it is a fresh sample, of course, the biologist will confirm before leaving the clinic that it's a good sample and that we can go ahead with the ICSI or with the traditional IVF procedure. By contrast, if there is any problem, we will share that information the sooner possible with you. So if required another sample, we will ask you.
All right, perfect. Thank you for that question, of course, and your answer to this. I just want to let you know, someone said that the sound is not so great. Please let me know if anyone has a problem with the sound, because for us here it's okay. However, please refresh the page just in case. Okay. All right. Thank you, Emily, for confirming. So this is. I don't think everyone else has a problem with this, so that's good. Thank you for confirming. And there's another question right here. After a failed cycle, can you use the time-lapse images to look at embryo development alone or together with gynecologist?
Yes, a very interesting question. We're always sharing the time-lapse video with all our patients for that embryos that are frozen or transferred. So of course, we will be very happy to share that information with you and to be transparent and explain all the development of your embryo.
Excellent, thank you. Okay, and there's a follow-up question. So is it embryologist or doctor?
So I'm doctor, medical director at Tambre Fertility Clinics, but we are very close with the embryologists. And regarding all the time-lapse system and all the information that are giving every day of the embryo development is the embryologist.
Okay, excellent. Thank you for clarifying that as well. And who discusses the PGD, the embryologist or the doctor?
So regarding the indication, if it is necessary or not, it's mainly the gynecologist, the doctor, but of course the procedure is the embryologist.
Okay, understood as well. Okay, and well, there is a question just in Spanish, so I will show you that.
No worries, I can translate if you want.
Yes,
so
please.
The question, Caroline, thank you for that very interesting question, is what are you doing with the embryos that are having mosaicism? So I will explain to all patients that when we're doing the PGD, the results could be absolutely normal, so they are called euploid embryos, absolutely abnormal chromosomes, so they are the aneuploid embryos, or there is a gray zone called mosaics embryos. Regarding mosaics, it's a very various kind of embryos, so we really need to talk with our genetics experts to confirm if that mosaic in particular is possible to be transferred or not. So regarding mosaics, it's very important to consider what chromosomes are involved. For instance, sexual chromosomes could not be transferred, or 21 chromosome, because could be the Down syndrome. But if the genetist is considering there is a low risk mosaic in terms of having problems with that baby, we will talk with our patients, and if they don't have euploid embryo, we will recommend to transfer. Even the implantation rate is lower and the miscarriage rate is a little bit higher, but we have pregnancies, ongoing pregnancies with mosaics embryos. So I encourage every woman, every couple, if they don't have euploid embryos, to transfer the mosaic if it is a non-risk mosaic.
Okay, perfect. Thank you so much. Yes, this is like a very common question, yes, when it comes to mosaic embryos. So thank you for explaining this to us as well. And thank you for your question. And now let me have a look. There is another question. So also, is best to opt for IVF or ICSI?
So a good question. Thanks a lot. So it really depends on each case. So depending what type of diagnostic, if it is a male factor, of course, we should go to ICSI. But it really depends, and we're a clinic that is always approaching very individual cases, and we're always talking with the embryologist before going ahead with the treatment, what is the type of technique they will be using on that particular couple or women. So when doing IVF, traditional IVF, we normally recommend that to do 100% of eggs with IVF, whereas to do 50% traditional IVF and 50% ICSI, and only do 100% of IVF if that woman in particular or couple have had a previous IVF cycle, traditional IVF, and has had good fertilization rates.
All right, perfect. Thank you again for answering and explaining this. And next question is right here. What's the best embryo quality to transfer? Because I hear people talking about grades.
So thank you. Yes, embryologists have different classification and different possibilities to identify an embryo, but usually blastocyst considered very, very good would be a 4AA, which means that it's really expanded. And regarding the letter is referring to the innocent mass that will be the baby, and the letter A is the maximum. And the trophoectoderm, which is the last letter, is also the placenta and other parts of the pregnancy, but not the baby. And also the best is to have a letter A.
All right, perfect. So again, for explaining how exactly it works, and someone is typing, so of course let's wait a bit and make sure that we have another question coming. Okay, just give it a minute. Nothing yet, so we need to be a bit more patient. But that's okay. Let's see. Okay, so any embryo with B grade isn't good. Anything you can add?
So thank you again for your question. So letter A and letter B are considered good letters, so good classification. Of course, A is the best, but B is also considered good embryos. Whereas C, it's really more intermediate and not that good, and D are considered bad embryos in terms of possibilities of implanting.
Okay. Thank you once again. We have another question in Spanish, so let me just show you that. It's right here.
Okay, so I'll just translate that question. So that question is asking if there is a possibility to anticipate possible low fertilization rate on day one, even if sperm parameters are normal. So at this point, usually fertilization rate is more to do with egg quality than with sperm abnormalities or sperm quality. So only in very abnormal sperm, very important and severe oligoastenoteratospermia, that would be the cause. By contrast, there is no possibility to anticipate regarding fertilization because that's something really considering egg quality, and there is any test to really confirm about the quality of the eggs before the embryo transfer is done.
All right, perfect. Thank you so much for your question and also for the translation. Thanks a lot. And of course, explanation. And next question is up right here. It is for embryo banking with PGT. When do you do the biopsy on the first batch of embryos?
So we always do the biopsy on day 5 of embryos. So it's always recommended to do day 5 embryos.
All right, perfect. Thank you. And the follow-up question, do you defrost or refreeze?
So at this point, very interesting question. So to do the thawing and freezing again of embryos, it's something that technically can be done. For instance, when we're having embryos frozen on day 3 coming from other clinics or that have, long time being produced, we do the thawing and we're leaving them to day 5. And if we have supplementary embryos apart from the good blastocyst to transfer, we will freeze again. And of course, we have I have many childs born after these techniques of thawing and freezing again. By contrast, if it is thawing and freezing again because we want to do PGD, it's not really indicate because then the quality of that embryo and the possibility of implantation will be decreased.
Okay. And there is another question actually. Does all these tests affect the embryo negatively?
Of course, all invasive procedures will not be positive for the embryo, but we will need to take care. And of course, supplementary embryos needs to be frozen because they will have potential success rates. And if by any reason there is any embryo that should be refreeze again, of course, we can have again possibilities in the future.
Okay, and there's another question from Emily. Or is it better to test after each collection?
Yes, that's absolutely fine. So the best approach for PGD is to create embryos, and every time that embryos achieve day 5 to do the biopsy, and not to do egg banking or embryo banking and then thawing and freezing again. So that's not the best approach. But sometimes clinics are doing this because of financial issues. But the best for your treatment is to do every equitrial.
Okay, thank you again for explaining. Emily has added on, I only get one embryo each cycle.
Yes, that's something that when considering a low ovarian reserve, it's possible. So we need to try to maximize possibilities to have more eggs and more embryos. But otherwise, we have possibilities to do, for instance, luteal phase and to do 2 cycles in the same month and having perhaps 2 embryos to do the freezing. But every time the embryo achieves day 5, it's better to do the biopsy. Of course, if the age is more than 41, I would definitely recommend PGD, even having only 1 embryo. By contrast, if there is only 1 embryo and the age is lower, then perhaps I would recommend not to do the genetic screening, because as long as there is only 1 embryo, and if we have said that it could affect negatively that embryo when only having one. Perhaps I would consider talking with that patient in particular and accepting the risk of transferring without PGD in order to try to minimize the impact on that embryo.
Excellent. Thank you again for that explanation. We have another question in Spanish. So, Dr. Laura, this one is for you. I'm not going to read it.
So, what is the best approach of stimulation when you want to do PGD? So thanks a lot for that question. And the best approach is to try to have the maximum number of eggs for that, patient in particular. So we need usually high dosage. We need to try to consider if LH is necessary or not. And depending on the previous protocols, we need to see if double trigger with double shot to have more metaphase 2X is necessary or not. And then depending on the number of X and everything, we will recommend doing the luteal phase and having 2 stimulations, so the double stimulation, to maximize possibilities of have more embryos.
Okay. Perfect. Thank you once again for explaining that to us. And someone is typing, so we need to wait a bit for the next question. In the meantime, let me remind everyone that if you would like to get in touch with Dr. Laura and her team, of course, from Clinica Tambre, you are able to do it with this link that I'm sending to you right now. And there is an option to simply click on ask your question, and all of your questions or requests will be sent directly to the team. So I'm sure they will be able to simply get back to you and provide you with some more details. I know that you require definitely lots of more details to be able to help a bit more. And I'm still waiting for some questions, so please let me know if you have any more questions. If not, we will be slowly finishing, but I definitely want to make sure that you have asked all of your questions. Yes, okay, there is another question in Spanish, so let me just show you this.
So there is a question talking about if the high dosage of gonadotropins, of the injections that we're using to stimulate, have a negative effect in the embryo development. So we know that the high dosage of gonadotropins, when we are considering maximum 300 or 400 units, it's not affecting negatively the embryo development, and it's more to do with equality. So we can only accept this situation when having more than, imagine, 25, 30x. By contrast, when the equitable is with less than these numbers, the embryo quality will not be affected.
Perfect. Thank you once again for that. Okay. In the meantime, one question popped up here. So what the amount of vitamin D is required when doing IVF?
Yeah, so normally the limit for general laboratories is 30 nanograms milliliter, so it's recommended to have a minimum of 30. So if it is less, we need to give supplements of vitamin D.
Perfect. Thank you so much once again for that. And again, someone is typing, so let me have a look. Yes, there is another question here. Is there an interaction between melatonin and aspirin?
Thank you for your question. Not at all, because these are two absolutely different. So melatonin is a hormone that we do secrete and create every day, but normally we can recommend to have vitamins with melatonin to increase antioxidants and to increase egg quality. And aspirin is absolutely different. It's a medication and it is involved in other paths.
Okay, perfect. Thank you again for this. And there's another one. Can you kindly repeat what you said about the low ovarian reserve and PGD? Also, is it available to a light IVF for low ovarian reserve patient?
So thanks a lot for your question. I'm very happy to help you. And of course, if you want to talk more in deep about your case, I will be very happy to have a consultation with you. So of course, yes, I can repeat. So the PGD societies recommend that when there is a very low ovarian reserve and possibilities to create more than one embryo, it's very low. Perhaps it's not the best approach to the PGD, because PGD ideally is when we have more than 3 embryos, for instance, and we really want to exclude what embryos are abnormal and really want to be sure which is the best embryo. By contrast, when we have a low ovarian reserve, if we do PGD, there is a high risk that that embryo in particular, for instance, could be damaged. So this is not the best approach. And for low ovarian reserve patient, there are 2 approaches: the mild IVF or the normal IVF with more important dosage. So we should consider how you're dealing with your previous protocols. And normally I do prefer not to do a mild IVF, because if in that person in particular it can have 2 eggs instead of 1, it's really doubling the possibilities. So if one patient is having 10 or 11 eggs, this is not big different. But if we're having 1 or 2 eggs, it's absolutely different.
Okay, excellent. Thank you as well for that advice and assistance with it. And well, I'm still waiting if there are any other questions. If not, we will be finishing for today. But I would already like to thank everyone for joining us tonight, for your questions, and I do know that it has been helpful for you. And Dr. Laura, as always, it is a pleasure to have you with us. Someone is typing, so let's give it a minute again. And yes, okay, it's a thank you. So we will be finishing. So once again, let me remind you that this has been recorded, so you will have a chance to still watch it within the next few days, as it will be uploaded on our site. And Dr. Laura, this is not our first webinar, and I'm sure there will be plenty more coming. So as always, thank you so much for joining us. And as you can see, there are some comments right here. Thank yous, but also someone has wrote, thank you so much. Hopefully get to see you in July.
Of course, yes. We're very happy to inform you that our clinic is open, and we will start receiving probably patients coming by car. So fingers crossed, July, our legal department will confirm if everything will be okay to see you in our clinic.
Perfect. Yes, definitely. Everyone is waiting in such case for July. So, and that is really good news. Fingers crossed you will be able to start all of your events pretty soon. And well, again, remember that if you simply follow us on YouTube channel or Facebook page or Instagram, you will be able to see all of our upcoming events as well, and you will be also notified when new video is uploaded. So I encourage everyone to go ahead and do it. Plus, let me well simply invite you for our next webinar tonight at 8 p.m. UK time. We will have another doctor. This time it will be a doctor from Ukraine, so we are going to Ukraine right now. Thank you so much again, Dr. Laura. Have a lovely weekend, everyone, and I hope to see you very, very soon as well. Bye.
Thanks a lot. Bye-bye.
Bye.